Bom, bom dia a todos. Aqui no Brasil vai meio devagar a presença de todo mundo, então deve chegar mais gente, como também os que estão online. Então, essa reunião eu acho que é uma reunião muito importante para nós pela possibilidade da internacionalização do programa, que é uma coisa que é muito cobrada pela CAPES e a gente nunca teve. Então, eu acho que é um passo importante do contato que a gente tem com professores internacionais e pode nascer daí eventual novas parcerias, alunos nossos serem mandados para lá. Tudo. Então, essa aula é muito importante para nós. Quem vai dar a palestra é o professor Reza Saidi, que vai ser melhor apresentado pelo Emerson, que é parceiro nosso, nesse ano aí que passou, que nos auxiliou muito na feitura o preenchimento do Sucupira e tudo mais, e continua nos auxiliando muito e sendo muito mais importante. E a ideia do convite foi dele, então eu dou a palavra ao Emerson para que ele apresente melhor o professor Reza Said. Tá ok, Emerson? Obrigado.
Obrigado, professor Quintanilha, pelas palavras. É um prazer estar aqui. O professor Reza Saidi, ele é da New York State University, e ele é de transplante, ele é Associate Professor of Surgery, Director Kidney Transplant Program, Surgical Director of Kidney Transplantation, Division, oops, Division of Transplant Service, Department of Surgery, Upstate Transplant Center, Sunny State Medical University, Governor at Large American College of Surgeons. Sorry, my English, because I don't know these exact terms. But, mas o professor Reza Said, ele é um especialista nessa área de transplante e também de cirurgia, e a palestra que ele vai proferir hoje é o uso da inteligência artificial no apoio da parte de cirurgia. E a parte mais importante aqui também para o programa é que o professor Reza Said, vai ser o nosso parceiro lá nos Estados Unidos, na New York State University, para que a gente possa também fazer com que o programa aqui da Santa Casa tenha essa parceria internacional que possa trazer professor, mandar professor, trazer aluno, mandar aluno. E isso é importante também para a avaliação e para que o programa possa se desenvolver em nível internacional. Então, a minha experiência nisso aqui, eu trabalhei na CAPES como diretor da parte internacional da CAPES e eu estou ajudando justamente a Santa Casa nessa parte internacional. Então, Professor Reza, is you can come here, so you have your time.
We have to sit down? I have to stand up? Or sit down or? Oh, then how gonna change? Yes. Start there? Oh, okay. And I have to speak. Let me see, make sure I know how this works. Is there a pointer here?
Yes, here.
This is the
Yes,
pointer?
this is the. Oh,
Oh, no. That,
come on.
and which one is pointer?
This is the pointer.
This is the pointer.
Yes.
Oh. I don't see any.
Just hold.
Oh.
He can hold.
Hold?
Hold, yes. Yeah.
Oh, that's the pointer. And how I change the slide?
Here. Next. and to back.
Okay. Okay. Good morning, everyone. I'm Reza Saidi. I'm a transplant surgeon, a hepatobiliary surgeon at the SUNY uh, Medical University in Syracuse, New York. I'm glad to be here, and thanks for invitation. I will also thank, my good friend Emerson arranged this. I think today I was asked to talk about the role of AI in surgery and transplantation. I think this is something that is a evolving field, is still a moving target. I want to just touch base with you. Then, what is this technology, and how can this technology help us in uh, transplant surgery and transplantation? But what is artificial intelligence? I think this is something that we should a little bit know. I'm not going to go through the full detail. All of us use computers, but do we all understand how the computer works? A little bit, maybe. Or all of us use car. I don't know how you are, but I don't know how car works. But AI, I think, is something that I'm going to touch a little bit about what is AI, and I think this is something good to know. And then at the other half of talk, I'd more about talk about using AI in surgery and transplantation, and especially the rule of robotic surgery. I don't know if that's something that you guys involve more and more. I don't know. In HPB, we do almost 90% of our HPB cases robotically. I know in head and neck, for example, I saw some videos they do thyroid surgery with, it's pretty amazing. But, AI basically, it's basically trying to mimic, our brain function using computer. When we, in our daily life, we capture a lot of data from, hearing, listening, and also seeing stuff, and then we can analyze the data and make a decision, and make prediction, those kind of things. AI is the same thing basically. They use basically a lot of data. Now we have what we call it living in the era of mega data, and basically can, based on forming these algorithms, they can analyze data, create models, and also based on that make prediction, make decision making, those kind of things. And they have a lot of application. Mainly I'm going to focus today about in surgery and transplantation, but also have other applications extensively in healthcare. And I'm not going to go through it, but there are some things that you should understand. We talk about AI. There are different components of this. I think there are some terminology you should understand. One is machine learning. Basic machine learning is using all this mega data and create algorithm, and based on those algorithms make prediction or decision. For example, I'm sure you are familiar, when you do a Google search online, then after that you notice that you get a lot of relative material later on about those things, and this is how the algorithm works. The other thing is deep learning. Basically is about basically using all these data sets about speech or face recognition, and based on this, then you can use AI actually create videos, stuff like that. Natural learning process is also basically using this data to understand, interpret, and respond to human language. I think this is something that I think probably you guys are all familiar using ChatGPT or Google Translate. Computer vision, using this data, create images or videos. And then robotics, I think I'm going to use this technology to do basically automation and use it to do mechanical work. I think this is, something, but there's a lot of, overlap with all this stuff that I'm not going to throw at this, between artificial intelligence, machine learning, deep learning, data science, statistics, that I'm not going to go to it. But as you can see, then this, using AI, actually overall, it's exploding. This actually graph shows how much time was to basically have these different applications used by 1 million people. You can see for Netflix was about 40 months. Instagram was about 2.5 months, but ChatGPT looks about 5 days. Each 1 million people start using it, and these, applications are changing. Actually, it's interesting. They said that every 53 days, a new version of it is coming up, and it's very difficult to stay on top of it. I don't know if you guys using, ChatGPT 5, for example. That came out in August, and now is a new version of it coming. This is rapidly, evolving. The amount of research and publication. This was the slide that I got from, American College of Surgeon meeting that was about AI. I can see the number of papers published about this in surgery or trauma is exploding. And as I said, it has to do with basically in surgery, we can use different components of this for data visualization. For example, we can actually use AI and train it, for example, based on 100,000 of videos that we have about, for example, gallbladder surgery, laparoscopic cholecystectomy. And based on those videos, AI actually can help you that if you have a gallbladder surgery, it can guide you how to do the dissection, especially if you have a pre-bad acute cholecystitis, and it's difficult to recognize anatomy. AI can help you. I think can be a complementary to the surgeon's role, and also can analyze all these huge databases that we have. For example, in transplantation, we have data of, all the way going to 1984, all patients' data, the donors' data. It can analyze that and create some algorithm for us. I'm going to talk about that, and can basically create these prediction models and help us basically to make better, decision making for our patient, and also predict our patient outcome. Safety measures, I think these are also very important when we cancel our patient, because every patient is different, and based on this huge database that the AI can create this algorithm, and we can actually go basically have a specific prediction for that patient. As I said, there's these databases, algorithm, and based on those can create a prediction. But there's a lot of flaws in it that we have to be careful. I think this is something that, there's a lot of talk about it, that what's the safety of this? Make sure that the database that we use is accurate, for example. And, make sure that basically we don't have a lot of missing data. That's also very important, because if you enter wrong database in this system, it give a wrong impression or wrong, prediction. That's why it's also a lot of talks about the safety of this technology, and basically also ethical, consideration for using this technology. This is one, I think, I don't know, maybe some of you or general surgeon are familiar with this American College of Surgeons, based on the database of thousands of patients, create this risk calculator. You can enter your patient data, what comorbidities that patient have, what kind of surgery this patient is going to have. Is this emergency surgery, elective surgery? And based on that, this algorithm can give you, some, prediction that what's going to be outcome of that surgery. What's the mortality rate, for example? What's the morbidity rate? What's the rate of, surgical, what's going to happen, what's the rate of surgical complication or wound infection? These are actually very important, that basically you can use this database and this, models that was created by AI to counsel your patient about different, options for that patient, and what's going to be outcome that patient. All of us, based on our previous experience, you have something in mind, but even an experienced surgeon maybe have done, let's say, 1,000 liver resections. But based on these models, you can use the experience of, thousands and thousands and thousands, liver resection, and it can give you a much better prediction. The other thing actually you can use actually in the AI just is about management of our practice, for example, how we manage the OR, how we can utilize this technology to basically better utilization of our OR blocks. I know each hospital have limited number of OR available to the surgeons, and we all competing for the OR time. These are technology can use it. I mentioned the other thing is about what we call it image guided surgery, that AI can complement the experience of surgeon to make sure, especially in difficult cases, to have better outcome of that patient, and also have a lot of operative measurements. What's for example, the operative time? What's the prediction? What's an anesthesia time? Those kind of things. And based on this, we can actually predict that how we can utilize our OR block. This is one example of that, as I mentioned. Oops. Moving. No? Okay, and I'm going to talk about, as I said, I think some of these things that I talk about is more management of, surgical practice, and then I'm going to talk about, automation. These are different things that I eventually mentioned about, you using, AI, computer vision is very important. Technical augmentation can be, augment our, uh, surgeon capability, especially in difficult cases, have a better vision and basically using different, for example, dyes, stuff like that can show you structures. Let's say you have a difficult colon resection, can basically show you where is the ureter is. Or you have a liver resection, show you the anatomy of the other side, that see how the tumor is closed. And these kind of image guided surgeries can very important using this technology and can improve the outcome of surgery. And you can, based on this technology, use your team evaluation and safety monitoring. As I said, there's also a lot of ethical and legal issues going on. I think each country has to develop their own framework that how going to basically monitor this data. There's also a lot of international, meetings going on that basically control this and monitor this at the international level, make sure the data that is is accurate and safe, and prevent misuse of this technology. In the second half, I'm going to focus more on using robotic in surgery. I think this is something for the audience can be interesting. Automation has been around for a long time. In the US, for example, 96% of now cars are, is automatic car. And since 2000, but basically when the Da Vinci robot became available, more and more surgeons try to use, this technology as the extension of laparoscopic surgery. I'm going to talk about it, that how this basically technology can improve your laparoscopic skills and actually help you to learn these techniques much, much easier. I'm going to talk about it. And we predict that by 2042, more than 90% of all surgeries it will performed by robot. I'm sure that the surgeons are familiar with this, but for the non-surgical colleagues who might listening to my talk, this is how it works. Basically, that usually the surgeon sits in a console at the corner of the table, and the robot, basically with help of assistant, they use these arms, and basically the surgeon can guide the robot to do this surgery. And this is actually, there are different advantages of this technology. One is that the image that you get from this technology is much, much better. But we do laparoscopic surgery for, I don't know, for you guys have done this. It's a 2D, 2D perspective. And you basically you lose your tactile sensation of the tissue. And the other thing, the laparoscopic instruments are, limited that in the motion. But this robot have, can exactly mimics our surgeon hand motion. But in surgery, we have to make sure that technology that we're using is safe, can provide a good outcome for our patient. And also, there's also talk about, cost, patient functionality, pain, and cosmetic. These are very important aspects of the surgery. In the past, we used to, do open surgery. Still in transplant, we still, I think the last specialty in surgery, they're still doing a lot of open surgery, but that's also changing. Open surgery is still, considered gold standard, and everything that comes after that, we have to compare it to open surgery. In the past, we used to say that big surgeon, bigger incision, but it seems that now it's going the other way. And then we're going to doing smaller and smaller surgery. Obviously, with the big incision, it was, associated with high morbidity. Length of stay was, longer. Patient have significant pain after surgery. Recover the patient was slower, and then cosmetic, because of this big incision, was a huge, barrier to this. Then laparoscopic surgeries gradually came in place, maybe I would say in the 90s, smaller incision, less pain, faster recovery for the patient. This is what the advantage of it, and shorter length of stay. And patient basically can go back to work and to their family and community much faster. But there was some downside to laparoscopic surgery, especially it's hard to train old surgeon to gain experience in laparoscopic surgery. The younger generation are much more facile with it, especially because you do a lot of this computer game stuff like that. But as I said, in laparoscopic surgery, one is about downside that was about the 2D view and loss of the tactile perception. The other thing was about laparoscopic instruments, because the laparoscopic instrument, there are very limited motion that you can do. Basically, doesn't when the surgeon uses hand, our wrist and hands can go in different direction. When you use laparoscopic tools, you cannot do that, and also that causes a lot of work-related damage to the surgeon. They call ergonomic injury. If you, I don't have the time to go through all this data, but in U.S., when the American College of Surgeons survey surgeon, 40% of them reported that in the past year they have work-related injury because of these instruments. They got pretty bad neck pain, shoulder pain, back pain. As you can get older, actually, some of surgeons actually have to retire early on because of this injury. But with robotic, I think the instrument that we use is much more easier, and also much more easier to learn. Because I remember when I started my practice, laparoscopic surgery was coming up, and I have to learn these techniques. It's not that easy, actually. But when you use it, robotic technology, it's much easier. And train, the new generation with robotics, it's much easier compared to laparoscopic surgery. The vision is much better, and the technique that you have to use is much easier to learn. But there's a downside to it. The other downside to it is cost money. But if you put everything together, I'm going to talk about the cost. There's some literature on this. I want to point it out to it. But if you put everything together, that, for example, I know the initial cost of surgery might be higher, but as technology advances, that cost has gone down. But overall cost to society is less, because that patients, go have less pain, spend less time in the hospital, and can go back to work or to their family and society much faster. These are some, example of this. For example, more and more centers around the globe, and especially in the US, using this technology for the donor hepatectomy. That's if somebody wanted to donate part of their liver to their loved one. And I think with this technology, basically, as you can see, the morbidity is less. Biliary complication was a big issue. And with this technology, you can better identify the biliary structures, and the rate of biliary complication, you can see it was 2% in robotic hepatectomy, 9% laparoscopic, 11% in open. The other thing is robotic nephrectomy. This is something also actually is more and more we utilize in US. That right now is at 30% of all programs using robotic nephrectomy. You can see the structures much better. You can also do the single port robotic nephrectomy. That's also can basically very helpful for the patient. As I said, cost is the issue. I'm going to bypass this stuff. But ultimately, because, as you gain experience, there's a shorter operative time. In the past, I remember setting a robot takes about hour and a half, but now we are more experienced. Our team is more experienced. Half an hour, they can set up the OR. The lower rate of conversion to the open, because you can see the structures better. In the past, the conversion rate was high, but now, I would say in our program, in the past 5 years, our conversion rate from robotic nephrectomy to open was 0. Fewer surgical complications, shorter hospital stay. I think this is advantage, but this costs more compared, for example, to a laparoscopic surgery or laparoscopic nephrectomy. Costs about $2,600 more. And if you, for example, our program, we do about 100 live donor nephrectomies and it costs about $260,000. But and in the literature pointed out, it added to $1.1 million, in U.S. health costs. But overall, when you add the value of this technology to the patient society, I think in general you make basically save money. In cancer surgery, also there's a lot of literature coming out. This is one of them, for example, comparing laparoscopic low anterior resection with robotic. I don't know if you can see, it's very small, but is much beneficial, because especially if you're doing it, operating deep in pelvis, especially male pelvis, is very difficult with laparoscope to basically do these maneuvers. And with this technology, actually, it's much easier. I'm not sure how's the experience here. For example, in US, a lot of prostatectomies has gone from, when the laparoscopic prostatectomy came on board, was very difficult to basically to expand that practice, because a lot of surgeons couldn't do it, laparoscopic surgery deep in the pelvis. But with this robotic, it's much, much easier. And now more and more, I think urologists uses this technology. In transplantation also is very helpful. I'm going to show you some data on using robotic surgery, but using AI in transplantation also can basically help us a lot in different aspects. For example, using all this database that I pointed out, that we can have better donor and recipient matching. In the past, we used to, rely on our experience, or sometimes we call our colleague who was more experienced. And what do you think? Shall we use this kidney on this liver in this patient or that patient? But now we have, with all this mega data that we have, we can use AI to basically predict that what's going to be outcome of this transplant, use this organ versus that organ. Can also help allocation system, that basically how allocate that organ to the patient, to what patient actually is most beneficial. Because in transplantation, we face the problem with organ shortage. And, for example, I don't know how's the situation in Brazil, but in US, we have about 100,000 people on the list to receive organ transplantation. And we roughly do, I would say, about 30,000 transplants a year. And a lot of these patients will die, unfortunately. Especially if you need a life-saving transplant, like a liver transplant, heart transplant, lung transplant, the mortality on those lists is about 50%. Because by the time the patient gets sick, needs transplant, you don't have that much time. For kidney, obviously, you can be on dialysis. You can maintain them on dialysis until they get transplanted. But for other organs, we don't have that. That's a problem. Organ shortage is a problem. And we can use, by using AI technology, can basically optimize the allocation and make sure that that organ can go to a more suitable candidate, and that patient can get more out of that organ. The other thing, you can predict transplant outcome, as I pointed out. You can use that technology that see what's going to be outcome of your patient after transplant, put everything together. And you can use that data to counsel your patient that what's going to be outcome of that transplant, and that what that patient is going to predict. You can use it for cross-matching, the tissue typing. That's also very important, because a lot of our patients have a lot of antibodies, and you can basically react to that organ, have rejection, and you can use this technology to predict this. The other thing, I think, in transplant, we use more and more AI, basically to assess organ viability. Because a lot of these organs, especially coming from a deceased donor, is out of body for many, many hours. Now we use this technology called machine perfusion. I don't know if you guys use this technology here. I would say for the past 10 years, we use that for kidney transplant. Now there are pumps coming out for liver, heart, lung, that you put the organ on this basically machines, and basically can mimic human physiology out of the body. And why organs out of the body is working. It's pretty amazing technology. Why, for example, the kidney is out of body, connected to this machine, is actually making urine. Or liver is making bile, heart is pumping, the liver expanding. And you can use the data that we gather from the machine with help of AI, can predict, is this organ suitable to be used or not? Especially now, because the donor pool in the US has changed dramatically. Again, I'm very excited to see how's the situation in Brazil. In the past, majority of our donors were young donors who would die in car accident. They were healthy, but they unfortunately have a head trauma and they die of head trauma. That I would say in the past 20 years, the roads are safer, cars are safer. That kind of donors have gone down. I think now is less than 20% of the donors we have in US are basically victim of car accident or trauma, stuff like that. Majority of our donors now are elderly donors who died of stroke. These are, older, they have a lot of comorbidities, and the quality of those organs might not be very good. And with this technology, we can actually put the organ on pump, and then in a couple of hours, we assess what's the functionality of this organ. The other thing is about, I want to point it out, obesity. Obesity is, a public health problem in the US. More than 50% of the, people in US have obesity. And their liver have a lot of fat infiltration. We call it fatty liver. And those organs are not very good for transplant. But with this technology, we can put it on pump. And also on the pump, we can defat the organ. And based on this technology, you can predict, is this function of the organ has improved? And based on that, decide whether or not you can use those organs. The other thing is about using, pathology interpretation of the organ, because a lot of this old organ we biopsy it, but most of the time, the recovery is done in the middle of night. There's no expert pathologist to look at that pathology. But with this technology, we can have this, expert, basically AI, look at the pathology and say how much chronic damage that organ has and whether or not to use that thing. The other thing I'm going to go, this is the other application of this. For example, the other thing is about immunosuppression personalization. In the past, we used this, one approach fit all, basically, situation. Everybody was taking same medication. And now with this technology, we can predict that what medication is more beneficial for this patient. I think in oncology, same thing. You can, based on using this technology, predict that basically what chemotherapy agent patient will benefit. And also more and more we're using, for example, in liver transplant, we transplant a lot of patients that have liver cancer, primary liver cancer or HCC or cholangiocarcinoma or metastatic. We start doing that for neuroendocrine tumor now with colorectal cancer. With this technology, can predict that what immunosuppression we can use for example, what chemo agent they will use. Robotic hepatectomy, I'll talk about it. With this technology, you can see the anatomy of the bile duct clearly, and actually AI can help you basically where to do the dissection, basically, for example, to basically make sure you don't damage the bile duct of the other side and the remnant of the liver have a adequate blood supply, and use image guided technology at the adjunct to the surgeon. Gallbladder surgery, I'm not going through all this stuff. That basically is a lot of data coming out comparing laparoscopic surgery with comparing open laparoscopic and robotic. And since robotics is more accurate in OBGYN, there's also a lot of data coming out using robotics for OBGYN surgery. In urology, as I said, is especially for robotic, prostatectomy. That's actually something that actually more and more urologists use, because in the narrow male pelvis is much easier to use this technology with more accuracy and less, surgical complication. Robotics in a bariatric also is a lot of data in our hospital. I would say 100% of bariatric surgery is done by a robot now. I don't know if I can show you this slide. This is actually from maybe turn down the volume. I'm going to talk about this is a right donor nephrectomy for you guys who have done this surgery, because the vein, you can see this is the IVC. The vein is very short, and with the robotic technology, you have a 3D view and see the structures very, in very precise manner, and then make your surgery much safer. And over time, when you gain experience, actually can be much faster compared to laparoscopic surgery, because the maneuvers that we can use with this instrument, you can see barely see any blood. It's almost like a bloodless surgery. It's making more accurate, and also we noticed that the patient at post-op have less pain compared to laparoscopic, because when you use laparoscopic, because you cannot do a lot of your hand motion, there's a lot of pressure on through those ports and cause pain. But with this technology, we noticed that the patient have less pain, and most of these patients actually go home next day, and they lose less narcotic. I think for the sake of time, I'm going to show the basically highlight dissection, finding the artery, vein. Is very accurate with the with great precision, and less bleeding, which is the key to success. I'm going to go over this, and then, as I said, for example, in the kidney transplant, we can use all this data that we have, and do data mining, create this algorithm, and use this algorithm basically to optimize our post-transplant outcome. And also, the other thing is you can use this to basically remotely monitor the patient. This is something, especially for our program, a lot of our patients actually coming from 100 miles, 200 miles away. And you be using that technology, you can actually monitor them outpatient without having to travel to us. Actually can provide better care. Bypass this. This was actually a recent publication about using a robotic transplant, using basic robotic technology to do a liver transplant, pancreas transplant. I think kidney transplant also is kicking off, and it's much better technology. And I think the future actually belongs to this technology, that basically we can not only in cancer surgery, other surgery, even in transplant, use this technology to basically provide better care for our patient. In summary, I think robotic surgery, as I said, is extension laparoscopic surgery, but it's much better because we can have a better 3D view, better economics, better handling of tissue, and ultimately lower mortality, morbidity, lower hospital stay. And also over time, I think with this expansion of technology becoming more available, I think the cost will go down eventually. But what's the direction of AI and robotics in surgery and transplantation? I think over time, with the advancement of technology, we can have a higher level of surgical autonomy for the surgeon and the robot to do this, and also make the real-time multimodal decision making in the OR by using better imaging in the OR. We can also use this technology to physiologically monitor the function of the organ, and also use this to personalize basically care for the patient. This is something actually is huge, but basically with all these new advances in medicine and medication, we can use this technology to see what patient will respond better to what treatment, for example. Predict organ allocation and matching. I'll talk about it. This is something that actually we try to basically change our transplant system in the US based on this technology. Make sure that the system is more fair to everybody and have better outcome because we have these scarce resources. Organ availability, we talk about it with this technology. Actually, we can basically assess organ availability out of the body and actually make sure that we use the right organ in right patient with good outcome. Assess pathology, as I said. Also, diagnostic rules to predict, rejection or bias in interpretation. Visualization or virtual planning also can be helpful with this in advance for the patient, that what treatment option is for the best for the patient. For example, how do you optimize patient condition before transplant or before surgery? For example, in surgical oncology, how basically we use, for example, neoadjuvant therapy. I think with these technology, we can actually better basically serve our patient. Telemonitoring and remote intervention also is very important, especially for the patient who live, for example, in rural area. They don't have good access to health care. I think that this technology can also very beneficial for those patients, to monitor those patients, have better access to healthcare for the patient who live in a remote area. And cost effectiveness, I think that's another thing that, especially with this technology, we can optimize basically cost too, and make sure we avoid, for example, providing futile treatment to the patient. And for robotics, as technology advance, I think overall hospital costs and operative costs going to go down. But as I pointed out, overall cost to society, it seems that by using this technology, the society makes money. But there's a lot of also, philosophical debate about this. Is this technology actually safe? Is this technology going to
Não pode ser
replace?
até 11h38.
A mic open?
Hã? Não é só você falar aquela nota. Não tem quarto. Eu só peguei e falei pra ela. Eu vou pegar aquele vídeo. Ela falou, tá bom, não.
Yeah, these are, there's a lot of also talk about, the safety and future of this technology. These are two good books. I recommend you to read it. One is from Noah Hariri, that talks about the age of AI and what are the, potential risk and also benefit of using this technology. The other thing is also about that with the, with using AI, I think a lot of jobs going to go away. But I think new jobs going to be created, and how we prepare the next generation for this new era, and how to basically train young generation for surgery, transplant, or also other work that automation is a big deal in it. I think there's also a lot of lively debates going on in, I'm sure in Brazil there's a lot of talks about this too, that how you use this technology basically to benefit the mankind. But I will stop here. This was wrong way. A brief summary that what's AI, how we can use AI in basically surgery and transplantation, and I would happy to answer any questions.
Hello, may I have a question? Make a question?
Alguém quer fazer alguma pergunta?
Hi, eu, Mário.
Ah, ele tá te ouvindo. Pode falar, Daniel.
Hi, Professor. Was amazing presentation. My name is Daniel, and I am a graduate with a master's degree in Santa Casa. I have a question about the training about the young surgeons. How over here in Brazil we have some trouble about the price, the cost, about to have the console and then train it. Nowadays we have the headsets like the MetaQuest and Vision Pro that you may have some kinds of things like as a training surgery. Do you see, in America, I don't know, it's already someone training with these headsets? Because I already saw some simulators in this augmented technology. But I don't know if it's all right, if it's okay. It's like to be in a headset of a console of robotic surgery.
Yeah, I think these are, both were a very good question. One is about the cost, and one is about how we train, especially how we train resident for this thing. I think this is something that are very challenging. I think the residency program in the US are also talking about this. But one thing I would point about, first thing about the cost, I think the cost, I agree with you. The cost is, high, especially, especially I would say in a lot of rural area that cannot afford this technology. But I think technology advances. I think overall the cost going to go down. We see this with other technology too, especially for example when we were trained with laparoscopic surgery. You know, this was the same issue was raised. The cost is much higher, but over time the cost has gone down. And then you know, when the people and the healthcare policymakers see that basically overall, you know, this is beneficial to you know, to the society, and cost has gone down over time, they you know, buy into this. For example, all these robotics that I pointed out in US, I don't know how's the payment system in Brazil, but in US, there is no other code for robotic, for example, like, let's say hepatectomy. We built based on laparoscopic, you know, hepatectomy. It costs more. I think hospital is losing money from this. But I think it attracts more patients, and there is a lot of lobbying going on that basically the insurance company now pays different for robotic versus laparoscopic. But this is something that is evolving. I think over time, I think eventually we'll get to there that this technology become available everywhere. For example, you pointed out about the robot. You know, robot is also very expensive. It's about what it costs $1 million. Our hospital actually rent robots because it's, and we always have, you know, this issue that, for example, there's no robot available because our hospital have 4 robots, and more surgeons are doing robotic, surgery, and a lot of times the robot is not available. What we're going to do? For example, a lot of times we say, okay, if there's robot available, not available, we have to go back to laparoscopic surgery. But if when the more companies starting building this robot, I know there are other companies building these robots now. The cost goes down, became more available. I think this technology can basically expand its utility and become available everywhere. But now I think I agree with you, because of cost, is not available everywhere. The other thing is about training. You know, I work in the hospitals, major university hospital. We have a lot of training. Also, we use a lot of this technology. How are we going to train our new resident for this? Because in the past, with open surgery was easy. But now with the robot, basically you don't have much. If you're a surgeon, a resident, sit down on that console, there's not much control you have over that. But that's why simulation is very important. There's a lot of simulation done that create modules that we can train the surgeon for this kind of surgery. I think in the past, the model was that you get trained in the OR. But now more and more training is going out of the OR. I think this is something also we have to work on it to make sure we can prepare the next generation to use this technology. But those are very good questions. A lot of debates going on about it.
Thank you very much.
Dr. Reza, congratulations for your lecture. Brilliant. Thank you for coming here to Brazil. And I think for the first topic of your presentation, I think the basic problem in artificial intelligence and applying in surgery, I think it's the big data, to feed the big data. If you don't have control of this and feed the big data, we're not going to have that answer we are talking about. Those answers we are talking about. What is the best organ to allocation for this patient? What's the best chemotherapy for the other patient or not? I think that is the basic problem of artificial intelligence. And here in Brazil, we have this is a huge problem to aliment good big data to answer those questions. I would like to listen from you for this topic. You asked about here in Brazil, what's the allocation of liver transplant organs. It's different from the United States. The death in the awaiting list is 50% is similar. but the last numbers of UNOS data, 1,008,000 patients died on the waiting list in organ procurement here in Brazil last year. And in liver, liver is the third organ after cornea and kidney. So that's our numbers. So for pancreatic transplant, 40% of the patients die in the wait list, primarily diabetic patients, okay? And the last question is about robotic and minimally invasive surgery and artificial intelligence. We took part of the last, we have the opportunity to take part of the last minimally invasive pancreatic surgery consensus that happened in the last Congress here in Brazil, the Latin American Congress here in Brazil of HPV. And we're talking exactly about the results of robotic surgery and minimally invasive surgery in high complex field like HPV surgery and particularly in pancreatic surgery. And what the literature showed to us when we grading the questions, there is not yet, we can't answer exactly if the robotic surgery is better than laparoscopic or than open in oncological results. They are similar, but I think the huge problem is because the availability of the technology on all the places and the problem of learning the technology and apply this in practice. So that's my questions, and thank you again for your lecture. Congratulations.
Thank you. I think those are very good questions. As I pointed out, the first question about the quality of data, that's a big thing. I think this thing before is, we can, I would say, is open for, prime time. We have to make sure the quality of data is there. I think we're not there yet. That's what, but I think it's coming. It's coming. There's a lot of things we have to sort it out, quality of data, regulation, for example, safety. Those things we have to figure out before this technology can be widely available everywhere. About your other comments about using robotic and HPV, I totally agree with you. The oncological outcome, I would say, is about the same. Is not worse, at least. But I think there are some advantage of this. Shorter length of stay, less complication, those kind of things. Yeah, those things are there. And then organ shortage, as you pointed out, it seems that Brazil is everywhere like this. Brazil, I think, is like U.S. because of organ shortage. We have, a lot of more mortality on the list. One thing I don't have the chance to talk about this organ shortage. I'm not sure you guys, I'm sure, heard in the news about this xenotransplant. This is a lot of hope coming out of it because for the past, it was impossible to use animal organs. But now with this CRISPR technology, we can do genetic modification in big animals, especially pigs, in a matter of a couple of weeks. And there are a couple, successful transplants they've done. A good friend of mine, Dr. Kawai, I don't know if you know him or not. I was trained with him at Mass General. They have done now 3 pig kidneys that were genetically modified in 3 patients. And so far, the longest patient who's still alive is about 8 months, doing well. But if I think with the invent of pig, organs, that can be a huge thing. But one thing, for example, that we don't know, that what genetic modification you have to do. There are different companies that doing, for example, 5, 10, or 50 genetic modification. I think AI can help with that with that decision making. That what kind of genetic modification you have to do. For example, this pig that they use at the Mass General basically have some pig genes deleted and some human genes inserted in the pig. But still, we don't know what's the ultimate outcome. For example, that patient that I pointed out have 2 rejection that they're able to salvage. and they still require heavy immunosuppression. You know, in the past, we have this problem with hyperacute rejection. That's gone out of the picture. Now this organ worked for a couple months, but they can have patient have more rejection that you have to heavily immunosuppress patient. But I think AI can help us that for example, what patient is better candidate for this technology, what immunosuppression we use, what the genetic modification have to make. I think these are something that are coming. I'm not saying this, for example, is out for prime time yet, costs a lot of money, those kind of things. But I think this technology can help us to make advances much easier. I remember when I was in training, it took years and years to get one genetic modification and create that gal knockout peak that basically solve the problem with hyperacute rejection. But with this CRISPR technology, matter of couple months, you can make all this, genetic modification. I think AI technology can help us too. But this is a lot of, still this is a moving target. I'm not saying is ready for prime time yet, but I think it's coming.
That's an interesting point. I can say in machine learning technology, we can put you on a cell phone how you're doing your surgeries on the intuitive programs. You can put in your cell phone, oh, my last hepatectomy lasted 3 hours or 4 hours. Now in robotic surgery, now I'm using the scissors and bipolar and the Dow, and I'm improving my
Yes,
my abilities in those. It's incredible, and in abdominal navigation in hepatic surgery is very important. I can preview the technology being applied in this kind of surgery. It's a very interesting field.
Thank you, Professor, for your phenomenal presentation. In Brazil, there are some resistance to robotic surgery adoption, especially in head and neck. So we are facing some difficult times here because of usually older surgeons who doesn't believe in the technology, and they are very strong with politics. So nowadays we have some problems with the federal board of the doctors in Brazil that doesn't allow us to perform endoscopic thyroid surgery, for example, outside of research protocols. So the question is, I know it's difficult and there's no an easy way to solve that, but how can we use AI to quickly gather data or something to convince those surgeons to, because we are doing that, we are doing robotics and we know this makes sense and it's good for the patients, but they resistant to that. And talking about training, when I the question from Danielle, when I did my training, my robotic training in 2018, there was no robotic training here in Brazil for head and neck, so I had to go to Pennsylvania, to University of Pennsylvania, and was more than $9,000 besides transportation and housing. So it was very expensive. And nowadays we have the training in Brazil, and it costs like $2,000. So it's way cheaper than it was like 5 years ago.
Yeah, these are the real challenges that you pointed out. We have the same challenge in the US. As I said, for example, right now, insurance company doesn't pay for all this. We have to build based on laparoscopic surgery. And I faced this actually with when the laparoscopic surgery was, became more popular. I was trained in that era. That's, for example, a lot of senior surgeon, very, prestigious surgeon came out, make a statement against laparoscopic surgery. Said, oh, this is dangerous, you're hurting people, stuff like that. But more and more people push for this. gathering the data is very important and lobby for it. For example, I remember when laparoscopic surgery was coming out, there was no, extra fee for that. When we built based on open surgery, we built, laparoscopic cholecystectomy like open cholecystectomy. But over time, by pushing this, showing the data that this is safe, saves money, despite the fact that maybe it costs more money initially to do the surgery, but in long term saves money. There's a lot of lobbying going on, and then to change the basically attitude of policymakers and society about this. I remember when laparoscopic surgery, for example, was coming out, some of patients were resistant. Oh, don't do laparoscopic surgery on me. I don't want that. I want open surgery. I think same thing. I think I see the same trend in robotic. I think it's all about showing that it's safe, is beneficial, showing the data that it's helping the patient, and lobby, and make sure that we change, educate the public, and also policymaker. I think those are the main things. Policymaker. Those are the folks who are making the decision about this. And overall, I think we can change the attitude. But is a challenge everywhere. Even in the US, for example, as I said, we have limited number of robots available in a hospital. And how we can, if everybody would do robotic surgery, we need to have 100 robots. We don't. It's a challenge.
And we spent like more than 10 years, right, to show that cholecystectomy by laparoscopy
it's not easy,
was better than open. So how can I avoid the same in thyroid surgery, for example, because the Chinese and the Koreans are performing a lot of robotic surgeries and resections, and we are trying to do, and we face this kind of resistance.
Yeah, that's the regulation is the main thing. I think one of the main things in the US, for example, to utilize this technology is regulation. You pointed out, for example, the paper that pointed out that about using robotic transplantation, most of this data coming out of US. Because US, because of regulation and limitation, is difficult to, expand this technology. But other countries, they don't have those regulation barriers to do that. And they are more advanced than us. For example, in HPB surgery, Koreans, Chinese, they are much more advanced than than US. For example, a lot of this limited program that the US are doing, for example, robotic hepatectomy, donor hepatectomy, their surgeons are not US. They're coming from Japan or Korea because they're more advanced. Yeah, that's another problem. Yeah, I agree with you.
New technologies take time. Usually take time to be.
Yeah, absolutely. A lot of resistance, always.
And thank you, Professor, for the lecture. And then also believe, as Bertelli said, I'm also a head and neck surgeon, and for especially for thyroid, we do mostly open surgery, and there is no video recording of the surgery. So to gather the data to improve AI, the robotic surgery and also the laparoscopic, the endosurgery with laparoscopic instrument are very important to have this data, so we can give more big data to improve the AI learning. It's another point to use that.
Yeah, absolutely. I think gathering the data, make sure the data is correct, accurate. That's a key thing. Yeah.
Alguém gostaria de fazer mais alguma pergunta?
From
Yeah.
audience.
So we, in the name of the program, we thank you very much for your presence, for your lecture and your visit here. We are very honored for that. Thank you.
Queria agradecer a presença aqui, a presença de todos que tiveram, e espero que a gente possa ter outras oportunidades de conviver together aqui em Brasil. Ok? Muito obrigado e uma salva de palmas, professor.
Yeah, I would like to also thanks for the invitation. I think it's good for us, to talk about this stuff. And I hope that this, visits could be open up the door for further collaboration and we can work all together.
Yes. Definitely.
Right about that.